Okay, atopic keratoconjunctivitis, AKC. Description: atopic keratoconjunctivitis is a serious, sight-threatening bilateral allergic disease that eventually leads to extensive conjunctival scarring. Patients typically have a strong atopic history with eczema, asthma, and hay fever. Onset is usually not until adulthood, although it may evolve from childhood vernal keratoconjunctivitis. Symptoms: as with all allergic eye disease, itch is the key symptom. There may be associated blurring of vision and a mucoid discharge with mucus strain. Sign: ocular. The lids are thickened, macerated, and fissured, and there is frequently associated blepharitis. The conjunctiva is invariably affected with anything from a hyperemic, flattened, velveting appearance with papillae through to extensive subepithelial scarring with phonical shortening. Resolved papillae superiorly may lead to typical limbal cyst lesion. There is frequently a significant mucus discharge. The primary cause of vision loss is corneal scarring. This results from a combination of conjunctival disease and or liberations of pro-inflammatory cellular products that have a directly toxic effect. In less severe case, there is only a superficial punctate epitheliopathy, whereas in severe case, this extends to include persistent epithelial defects, stromal scar, and extensive pannus formation. There may be superior limbal infiltrates and tantrum dots. In severe case, an anterior subcapsular cataract may be developed. There may be associated signs of keratoconus that possibly develops secondary to the extensive eye rubbing that characterize this disease. Skin: atopic dermatitis typically affects the flexure and should be looked for at the wrist, antecubital fossa, neck, and on the eyelid themselves. Management: allergens avoidance. Cleaning around the eye and flushing of the inferior conjunctival fornix with lubricant soap can be useful in clearing allergens from the ocular surface during the acute attack. The early involvement of an allergist, usually via GP referral, is important to ensure optimal control of the multiple allergic disease often present in these patients. Therapeutic: many different drugs are used typically topically to control ocular surface inflammation. Antihistamine: unfortunately, these drugs are of limited usefulness. Combined antihistamine mast cell stabilizer, petadine, and ketotifen, quite effective and do not have the side effects seen with steroid. Should be used throughout the year. Non-steroidal anti-inflammatory agent, ketorolac, quite useful and often used in addition to mast cell stabilizer. Corticosteroids, extremely effective in managing acute exacerbations. Long-term usage of corticosteroid is often associated with side effects, and therefore they are restricted to the sparing use of drugs of lower efficacy with poor ocular surface penetration. For example, fluoromethanol. Advice: advise patients of the importance of avoiding aggressive rubbing of the eye. This contributes to the development of both the ptosis and keratoconus.